Welcome to the NeuroCog Podcast, a human-focused series framing autism in the process of differential diagnosis from a historic to modern-day perspective. I am Dr. Myah Gittleson, a clinical psychologist and founder of Gittleson Psychological Services in Los Angeles. I specialize in children and assessments for developmental skills and autism spectrum disorder across the life cycle. I'm passionate about helping families understand autistic neurology in a way that feels human, empowering, and practical. I do this work because every child and every family deserves clarity, support, and the tools to thrive. I'm joined today by two very special co-hosts, my dad, Dr. Jay Tarnow, founder of Tarnow Center for Self-Management in Houston, Texas, and my friend Neil Hughes, a savant with autism and founder of Enscape, assessment and training company based on narrative medicine.
Today's episode is Barriers to Assessment. What is a barrier to assessment and how do we overcome?
I tell the parents every time, the point of today is not to stress out your child. You know, some parents will get anxious that they didn't have behaviors in front of you.
And there's very little education about autism in general psychiatrists.
I have someone testing me that doesn't understand my neurology.
So everybody has their own agenda, and what I say a lot of times when I see parents is, I don't work for anybody but the child who doesn't have a voice. I'm here to be their voice, and that's who I'm working for.
There's a gender bias in the history of assessment. Mm-hmm. So accessibility can be a multitude of barriers to entry.
Right. You know, yes, there's accessibility problems across every assessment and then also intervention.
An autistic person will parallel play, they'll parallel storytell.
Right.
And they're told they don't have filters and they have inappropriate speech.
Right.
But when I'm with other autistics, there is no inappropriate speech.
Right.
Because the standards are different.
Dad, you mentioned this with drug companies, funding their research, right? They already know what they want the outcome to be, and so they can mold.
This part is called hot seat. Jay on the hot seat.
But my personality is a big personality, and because of that, I can get it across on the video and engage people in a similar way. But it's still, not the same thing.
I don't care if the tools aren't standardized. I'm saying the feeling, the engagement that's where I felt was wrong about telehealth assessments. So I had to learn about this phantom spectrum because that wasn't what I was taught in school, that it didn't exist yet.
But there are very few people who know about this, and that's an accessibility problem because it depends on where you are in the country and where people were trained and what you have available to you.
I think that we give too much weight to the evaluator's own agenda, own emotions, own subjective interpretation. And that's where the fault of the tools, I feel, are that we're given. I was excited to learn about quantitative EEG. Let's go to the source.
Look at the brain.
Look at the brain. Look at the source. How is it functioning? It's not going to lie to us. It's not going to be our interpretation of what their brain, this is the brain waves. These are what the brain is telling us. Welcome back. I'm Dr. Myah Gittleson here with my father, Dr. Jay Tarnow, and Neil Hughes. We're discussing differential diagnoses.
And what we were talking about, the utility of an assessment. So what's the value? How do we use it? And whose purposes are we meeting?
Right.
And that led to the idea that even if you need an assessment, it's sometimes hard to get one.
Yeah, accessibility.
And then when you do get one, sometimes it's the wrong one. So there's a lot of accessibility issues.
Right.
Getting the right one, being able to afford it, cost,
I think accessibility is a big one. Break it down state by state. Each state has a different layer of how to have access to assessment. So it really depends where you live. Here in California, I feel like we have more accessibility. However, like you brought up, is it the best option for your needs?
Right.
So there's many people that do assessments here in California, different resources, but I don't know if all assessments are the same.
Yeah. So when we in this moment of filming a podcast for people that are thinking about if they or their kid needs to understand themselves better, my answer is we need to make it more accessible.
Right.
it needs to be a cost thing and how long do you wait for it? Because sometimes accessibility is about a 5-year waiting list.
Right.
Because you qualify for a benefit and you don't have the money to pay out of pocket.
However, scaling the assessors, and having them all be, like I said, have the same end result, the same type of assessment is the tricky part.
Mm-hmm.
I think in COVID, there became more accessibility because people found ways to do telehealth evaluations. So we could talk about that. Now I'm still seeing people doing telehealth evaluations, and I don't know if it's for the right prompt or reason that they're still doing
it's
telehealth.
Not in person and it's not in the elevator.
Right.
It's less information.
Right.
And what we need is more information.
Right.
I agree with that.
If you want to go back in time during COVID, it was really interesting as an assessor who I said immediately, I can't do my job online. And everyone's like, yes, you can. I'm like, how do you do a job of an assessment where part of my assessment is feeling that co-regulation moment with the child or that connection, and part of my diagnostic process for me as an evaluator is having that feeling, and no longer can I have that happen. So I only stopped in person till May. So we shut down in March. I was back in the office in May doing face-to-face assessments for whoever wanted to come. Yes, of course, we would offer the telehealth, but whoever wanted to be in person, because I just felt like there was such a need to still have a good assessment.
Right.
But
that can't stop.
I was going to say that the problem, by the way, Myah, is none of the assessments are regulated on video. So in other words, they're right. I mean, so they're all normed in a certain very circumscribed way, in this very specific manner. And when you do it on video, you don't have that same aspect.
No, but Dad, you're going back to that structure where I'm trying to get away from that. You're going back to, you're going back to that.
I know.
Those tools, right, are standardized, the standardized method way, and you can't, again, have the parent in the room compromising the test, I'm just saying, I don't care if the tools aren't standardized. I'm saying the feeling, the engagement that's where I felt was wrong about telehealth assessments. That piece you couldn't do, Right. I mean, I think with the ADOS, at least, the team and Catherine Lord came up with, well, we could do a different version of the ADOS, and we could send the parent materials and have them on the other end in the video with the materials. And we're doing the ADOS in a variation because of COVID. And they did all of that work. They worked really quickly to be able to do telehealth assessments. Mm-hmm. But I kept saying, you're still missing the biggest piece of my process is being in the same room together with the child. So I couldn't do it. So I just decided I'm going to keep to the regular assessment. You're going to come to my office. No one's going anywhere but home in the office. And so I felt very safe to still do in-person assessments. So, but however, getting back to accessibility, I think it showed people that they could reach further out because now we have this option of doing an assessment over telehealth. And so it gave some more accessibility at the cost of something else.
Clarity or resolution.
We have the same problem now. In my practice, only about, I would say, 50% of people are coming into my office. Most of them have chosen to do the telehealth, which is, far inferior. Mm-hmm. Luckily, I can do the telehealth because of doing medicine and having, going back to the medical model of asking questions and so on. But it doesn't really give me the breadth of it. And I don't think I can really do effective therapy with telehealth in comparison to in person.
And there's a barrier to entry with these things that can happen at multiple levels. So cost, ethnicity, you can find people that won't serve your community.
Right.
So there's large populations there's a gender bias in the history of assessments.
Mm-hmm.
So accessibility can be a multitude of barriers to entry.
Right.
You can be trained, and I've been training myself to be able to do video therapy with patients. But my personality is a big personality. And because of that, I can get it across on the video and engage people in a similar way. But it's still, not the same thing.
Mm-hmm.
Yeah. But yet the society wants it. Society, it's what you said, Neil, it's a accessibility, because now I can reach people in rural Texas who don't have to drive 3 or 4 hours to come and see me anymore.
Right. So, and then there's another layer of accessibility where the agency or the school district or whoever's paying for the assessment says, we're not doing the autism. We're not going to include that because that'll be a budgetary pressure to then provide a Medicaid waiver or some kind of expense. So sometimes we don't have access to the assessments that we need. We don't have access to it because of the people paying for the assessment isn't the patient. That's what's shifted in my story.
Right. And I think, the decision makers of what assessment's going to be conducted, especially with the IEPs, I see a lot, if a parent doesn't bring up autism, they don't include it in the assessment. So a lot of my kids will have speech and language impairment as their eligibility for an special education program. And I'm like, well, wait, this child has a diagnosis. Why wasn't it looked at? And it was, well, the parent didn't bring it up. The school was like, okay, they have a speech delay, without even taking in consideration there might be other things, unless maybe somebody brought up that concern.
Right. So stigma plays into accessibility when your parents are embarrassed that they have an autistic family and this one child is exhibiting the autism diagnosis.
Right.
That's how I think of it. That everyone's got some neurodiversity in there. Everyone's got their own unique fingerprint, but some families are so different. And then there's that one kid that just is not working out, but they don't want to talk about it. They just want minimal efforts. And then I've also heard parents saying, I'm being coached by the employees of the school psychologists to say, don't get autism diagnosed, get ADHD, because there's more resources for ADHD. So there's an accessibility with the child not learning about their autism because it didn't serve the needs of the school. Right.
Or actually, it's the opposite, really, that ADHD, you don't get as much and you get more. They don't want to have to fund autism.
Well, that's been my experience, but I'm hearing that there's also people.
It depends on, the spin of it, right? Because the parents want to hear the ADHD, right? That makes them feel better. Oh, it's just ADHD. And then the school was like, oh, thank goodness we don't have to open up, autism where there might be more services to provide. Right. So everybody has their own agenda. And what I say a lot of times when I see parents is, I don't work for anybody but the child who doesn't have a voice. I'm here to be their voice, and that's who I'm working for.
So when you say that, my metaphor brain says, oh, you have an engineer hat for the kid.
Right.
And you put them at the engine level of the train. And everyone that asked for the assessment is in the coal car and further back.
Yes. Yeah.
And this is why I say I'd like to have met you guys in 1985. Because my tracks would have been different. And is that violating your license to do that?
To be their voice?
To actually do no harm? Is that violating your...
Is it doing harm putting them at the?
No, I'm saying I've been harmed by being put in the back.
Oh, sorry, I wasn't following. Yeah, do no harm. Yeah, exactly. I mean, that's the same thing when people come to do the assessment, and and it's not going as planned, and I'm not getting my scores. And I'm like, I'm not here to do harm on your child, to traumatize them, that I have to have these scores done today. I will stop an assessment in terms of the score part, because it's okay. I've gotten enough of information that I need for your child's diagnostic assessment. I'm not going to sit here and traumatize them that they must sit here and do puzzles and blocks for me right now.
Right. And the puzzles and blocks are putting things into shapes from...
Right. And that's what gives you the scores, right? And some people will panic or get anxious that the report's not going to have shown that they did work. As like their work, right? Their performance is assessed by the report, and the report has nothing in it but observations. They didn't do their job. Which again, I look very differently. I'm not going to stress a child. I tell the parents every time, the point of today is not to stress out your child. Some parents will get anxious that they didn't have behaviors in front of you, but because they're regulated and everything is good here, and that's okay.
Do you understand how different that is from my own experience?
Yes. I do, because I've heard, others have similar experiences to you, and I've read reports that show me the different experience by reading the information.
Yes.
But that has helped me do things differently.
Right. So I've been diagnosed with a speech delay, that differential between my cognition and my word acquisition. And they said, you have a speech problem. And I said, okay, state of Virginia, I'm going to go find out what my speech problem is. And I went to University of Virginia with my Medicare. So I paid for it through my primary care. I said, I've been told through this report, and I gave them the report, I need to be tested for my speech and speech pathology. And I have inappropriate speech. That's what I came back with.
Right, you didn't qualify for speech therapy.
No, but I have inappropriate speech.
Inappropriate speech.
Do you know what was the inappropriate speech?
What?
My history of felony sex abuse and torture. They said, what brings you in today? I'm like, I have a developmental disability from felony sex abuse and torture.
But what assessment tools did they come up with to say that you have inappropriate speech?
Because I was talking about something that was inappropriate.
Oh.
Because it's inappropriate for people who have been traumatized to talk to a speech pathologist about their trauma.
And that's just one example. I mean, there's so many inappropriateness moments I have in my assessment, in my Girl Squad groups, of their language, everything landing in the topic of inappropriateness and bringing it back all the time. I would never say that person needs speech therapy.
But is it inappropriate? Or is it just different? I have different speech, but it was on topic.
It's how you it was on topic for the prompt,
for me,
right?
But not for them. It made them uncomfortable.
It was on topic for the prompt. So I don't know if that's inappropriate, because that's in context, right? But I think sometimes it's also the way I see individuals socializing is to bring up inappropriate things as how they socialize. At least in my context.
Absolutely. An autistic person will parallel play, they'll parallel storytell.
Right.
And they're told they don't have filters and they have inappropriate speech.
Right.
But when I'm with other autistics, there is no inappropriate speech.
Right.
Because the standards are different.
Right.
So that's an accessibility problem. I have someone testing me that doesn't understand my neurology. And so then I get a label of inappropriate speech that goes back to my medical record and then impacts everyone that works with me as someone that has maybe not Tourette's, but he's getting there. Mm-hmm. He's on that spectrum. I really hate that term. I don't want to be on a reservation and I don't want to be on a spectrum. I'm human.
Right.
And I had reasons for saying what I was saying, and I was actually doing it because they needed to know that I'm in a process of understanding myself around my early childhood trauma, not my autism. Right. I don't have a problem with autism. I have a problem with what people did to my body, and then how the laws and the judicial system and all the trauma, that it literally dysregulated me, and that SMR training which is another accessibility issue, is how do you get neurotherapy?
Right.
If you need an assessment for not just autism, but let's say you have a TBI, and you come in and say, oh, well, it looks like we've got cognitive issues, let's try these therapies. Some of those therapies, there's no way ever a person on Medicaid, Medicare, is ever going to get a cue or the neurofeedback that's needed.
Right, right. I mean, that's, yes, there's accessibility problems across every assessment and then also intervention. In terms of my dad, I don't know how many psychiatrists are really accessible. When I see a kid and the parent is exploring medicines, or I think maybe this is a child that maybe needs medication consultation, I always say, please try to find a psychiatrist. But I know that I'm saying that with I don't even know if that's really available to them.
I love that you're bringing that up. Can I just say,
yeah.
I was in psychiatric care, and I like psychiatric care till 2024. I got my formal diagnosis in 2023, and I just sent it in as a routine. I like my medical record to be complete. My next routine visit with psychiatry, the attending said, people like you don't respond to medication. And I'm like, the only thing that changed is I have a formal diagnosis of something that I knew I had the whole time. And now that you have a formal diagnosis, how does that change the relationship with me as a patient? What changed?
Well, I think that in the medical field, not all, but some will think that there's no medicine to treat autism. So looking at maybe medical history of medicines you tried didn't work because what we know is the brain is functioning differently, therefore medicine's going to respond differently, therefore it might not be successful.
Yeah, it didn't make any sense to me.
Yeah.
So that's an accessibility issue.
Mm-hmm.
So not only once you get the assessment, then you get cut off from care. Because the word autism, like Jay pointed out, is actually that person's schizophrenic. These words have baggage that is embedded in everything that we do. Words have meaning. Even if we don't know the whole history of the word, there's still a valence of, oh my gosh, that's the worst of us.
Right.
I don't know a worse term to have than a person with autism in history.
Borderline personality disorder.
But that's not a child, that's the woman that's graduated from hysteria. And women still have more power than young children.
That's true.
I'm thinking about the socio-biological and economic. Mm-hmm. That when you label a child as schizophrenic, and it's such a terrible thing, you change it to autism. That's a legacy that I live with by being I'm openly autistic with autism, and I do these events, and parents are bringing their kids to these events. And one of the kids said last time, he's like, is the man with autism going to be there? Because this kid doesn't know if he can make it through school, and he knows that I made it through school. Last time I saw him, I'm like, yeah, I've gone through school. And it wasn't easy. So not only is there an accessibility problem with the assessments, but a lot of the activism around being autistic means that kids that are not enlightened with parents that are willing to do the social justice, they're going to be labeled with autism, and that is such a desperate place to be for a kid. The stereotype of autism is you are not human. You are subhuman. You have no theory of mind. And this is from the 90s. And so accessibility is everything. And the way we create accessibility is we normalize the difference. And that's what Temple Grandin is so good at. That I'm different, not less than.
Right.
But these kids, women with borderline are untreatable, but they're not said they're less than. They're like too much.
Right.
But autistic people are not enough. We're not enough human. We're subhuman.
But I don't even know how you define subhuman.
No theory of mind. Not able to connect, not able to know what other people are thinking.
But that's so interesting because that's debunked a lot of times over and over again.
And it's not a real thing.
Right.
It's a mistake, but it's still a legacy issue.
Right. It's a mistake. I mean, I'm reminded of this daily in my office when I'm trying to write a report on a child that actually did give me eye contact, right? So this goes back to not every assessment's the same. I don't want to hear a response of my child makes eye contact, therefore they're not autistic.
Yeah, eye contact has nothing to do with my autism.
Right. And so I look at eye contact very differently. I tell the parents, I don't want to hear a yes and no. I always say, describe your child's eye contact. Because it has to be, of course, when we're going through, because we have the DSM, we are held to that standard. If you want them to get access to care, right? And that is my goal for a lot of these, individuals to have access to care. You have to play the game and you have to follow the diagnostic criteria that's going to line up. But I do ask it in a way that I want to know, describe your eye contact for me versus does your child make eye contact? I try to, and a lot of times in my reports, I'm spelling out that the child provided eye contact when they're attending to their parent or, when they're making a demand of their own, when they're socially motivated, basically is what I tell the parents.
That's what eye contact's for.
It's for social motivation. And a lot of times they're not socially motivated.
Humans do not motivate me.
Right.
Salamanders motivate me. And skateboards. Mm-hmm. And trains scare the crap out of me. So I like model trains that I can control because they don't shake the earth.
Right.
It's the shaking of the earth that antagonizes my nervous system and makes me stare at trains, like the one that went by earlier today. Mm-hmm. It's not normal. That's not a natural thing. It's very dangerous to me. And then to ride in a train is a whole other thing. And I rode in trains as a young child. I also wore cowboy shirts as a young child. And I'm not a time person. So accessibility also has to do with not just when we talk about, well, here's where he's not performing. It's also like, we didn't even think to ask that.
Right.
Like the accessibility of, where's the questions about how itchy am I? No one ever asks about my itchiness, and I have anaphylaxis. I've been given an EpiPen, and they don't know why I'm anaphylaxic. But here's your EpiPen. And I said, does this have to do with my autism? And the allergist said, why would it have to do with your autism? And then I gave her a quick rundown of how people with autism die early and they have autoimmunity and they're allergic to food and the environment and other people's feelings. She's like, oh, so you're saying that you're an allergic person because of your neurology? I'm like, yeah. And it took 5 minutes and she had compassion for me. Mm-hmm. But she's not assessing me, wondering if I'm autistic. It's not a tool in her toolbox.
Right. And then that leads to the emotional part of the assessor, right? I mean, you're talking about not every assessment is the same because the assessor brings an emotional component to the direction of the assessment and findings.
Right.
I think that you mentioned this with drug companies, funding their research, right? They already know what they want the outcome to be. And so they can mold.
This part is called hot seat. Jay on the hot seat.
Well, I mean, I think it's a concept, right? It's like if the assessor doesn't want you to have autism, right?
Yes.
They are going to walk in already deciding that they're not making a diagnosis today.
I believe that autism is also the worst label to have because it doesn't make the amount of money that bipolar makes.
In the medical model, but you walk in to the world of private equity investing in ABA providers these days, it actually is this, I don't even know the numbers to quote because I'm not in the business world of it. I didn't start doing this to make money. I'm not doing this now to make money.
But what is ABA if it's not part of the medical world? Now I'm confused. What world is that in? After school programming?
No, I mean, I guess it's still a medical. I don't know. Maybe I look at it as medicine. Bipolar makes a lot of money because bipolar, great. The only thing that helps bipolar is medicine. So if you make that diagnosis, you are writing a bunch of, prescriptions. If you're I guess for me, I'm looking at ABA as an intervention versus medical treatment.
Mm-hmm.
I don't look at ABA as treatment.
Yeah, and the same thing with bipolar, right? I mean, there's more to treating somebody with bipolar than just giving them medicine. There's an awful lot of work that needs to be done with them in teaching them a bunch of skills. The most important is to recognize when they're getting depressed and when they're getting manic.
When do you have patients with bipolar that are in remission?
In remission? Do I have patients? Yeah, they have it's the same thing as autism. Let's talk about this with these diagnoses. People go through life. And when you go through life, it's not easy. There are a lot of things that interfere and traumas, as you point out, occur. And the child, depending on their capability, has to be able to deal with it. Sometimes if they have autism, they're not going to be able to deal with certain things that occur in life. And it's going to affect them and change them and make them angry and rebellious and all kinds of different things. But also, people with autism can have depression. They can have anxiety. They can have PTSD. They can have lots of different diagnoses as they age and go through different developmental stages. I think that's the problem, is when you use this autism and that the treater is not really comfortable with autism, and they don't really have an education about that these are people who grow up and go through various stages of life and have difficulties with those stages. What do you do with them? Well, they have autism, so they shouldn't be depressed. That was one of the cases I've just seen, where the parents were telling me that autistic people don't get depressed, which is not true.
That's an accessibility problem. Because if you believe something that's not accurate, and then you're denied coverage or you deny treatment, then so even after the assessment, there's still accessibility issues.
Well, the accessibility has a lot to do with how people are trained. I think that's what Myah is pointing out, is that the training of the professional is very, very important, and what they feel comfortable with, what they're trained to do, and what they understand, for instance, about autism. And there's very little education about autism in general psychiatrists, adult psychiatrists, very little. And it's becoming more and more as we've identified more and more people with autism, and they're also living longer, right? And so they're going to go through all the different stages that everybody does. And as they do that, dermatologists, immunologists should understand that people with autism have much higher incidence of allergies and autoimmune disorders. That's just part of the whole medical diagnosis of understanding somebody who has that. But there are very few people who know about this, and that's an accessibility problem, because it depends on where you are in the country, and where people were trained and what you have available to you.
Right. So I'm curious to see if, when we talk about how assessments can work now and in the future, what is a clinic? And I'm trying not to derail the conversation, but that's really what I'm curious about, is how does your clinic, Jay, differ from Myah's, and what does a clinic look like in the future? Because you guys are both focused on what the brain's actually doing. What is the brain working at?
But I want to go back to the Kennedy Centers. It was incredibly good, because at that table, I had, when I was learning, but at the table, when we went through cases, there was a neurologist, a developmental pediatrician, a speech and language therapist, a neuropsychologist. There was a whole team of people around talking about that case. And also, by the way, the atmosphere, which everyone was being challenged. Now, I don't know if that was just because it's New York, but everyone was challenging everyone in terms of coming up with an understanding about the case. So I think the Kennedy Centers were the major step in terms of this country getting people aware that you need a multidisciplinary team with a whole bunch of information to really make accurate diagnoses of people and not just take a quick look at somebody.
Is that continued on into the future? When what you experienced, do they still do that in places?
And yes, in certain places. When I went to do my residency and my child psychiatry fellowship at the University of Colorado, they had a center also that did the same type of evaluations. And you know, they didn't, when you come to a center where everybody is working together, that gives you better care. And when they've had a history with each other.
I don't know about that, because I read assessment. I mean, maybe again, it's specific to the state and the team, right, and so many different factors that's not scalable. Because when I read some assessments from some of the teams here that have that multidisciplinary team approach, I'm still finding the same frustration with some of those outcomes of those assessments. It's not helping the bias piece of it for autism. And I'm focused on autism. I will say a lot of my assessments are differential, but at the end of the day, focusing on that diagnosis and differentiating between other things that it could be, or differentiating coexisting. But in terms of the world of a diagnostic assessment, looking at autism, I'm finding frustration that when you have the multidisciplinary team, it doesn't always equal out the same outcome I'm having just one person looking at the case.
Well, that's because some teams, though, are just agreeing with each other.
Right.
And trying to get through things. You know, when I left being in full-time full-time academia, when I set up my practice, it was a multidisciplinary team of just what I had in my academic background of having those people. But maybe the difference is that the group of people who I work with didn't allow people to take shortcuts. There was always questioning, okay, what exactly are you talking about? What does the testing show? Why should we trust this testing? You know, all those other pieces are constantly were constantly being discussed.
Right.
And not all places do that. Some people just go the periphery, you know, and just getting it done and the evaluation, and everyone throws in their report and that's it.
Yeah. And then maybe it's only geared towards the leader. I mean, it goes in the way of the leader maybe too. I mean, that was your approach to it. So that's how you were the leader of that discussion. So everyone followed your lead and modeled that versus just cut and paste their different portions. You led that.
Right.
Whereas and then there could be a leader that, again, their outcome is we should not make any diagnosis of autism. And so the lead on that is we're going to make sure all the data doesn't support the diagnosis at the end of the day. I don't know. I feel like there's so much weight, and this kind of goes to our next episode probably, but there's so much weight on the emotion of the assessor or the leader of the assessment team. You know, what their agenda is, what their secondary gain, and whatever they're bringing to the table. They might have their own child influence piece of this, their own history of their own childhood or their current, you know, children that they have. I know for me, you know, I have 3 children that are very, very different. All 3 brains are very different brains. And I love learning about all of these things and their differences because it does help me be a better assessor. And I hold no shame, guilt, anything related to what I was dealt with my children. So I can be very open and don't feel like if I make this diagnosis of autism and my child's doing the same thing, that, that means my child has autism. So if I deny that this child has autism, equals out my child doesn't have autism. Like, I don't go there because my son, my oldest son, he didn't speak till 4 years old. His first language is sign language. And, you know, he taught me a lot about the work I do through that process. So I think that we give too much weight to the evaluator's own agenda, own emotions, own subjective interpretation. And that's where the fault of the tools, I feel, are that we're given. And that was why I was excited to learn about quantitative EEG, was let's go to the source.
Look at the brain.
Look at the brain. Look at the source. How is it functioning? It's not going to lie to us. It's not going to be our interpretation of what their brain, this is the brain waves, these are what the brain is telling us. We don't have to interpret that. We just have to analyze it based on previous records of other cues that we're analyzing and comparing and getting biomarkers to. And it's black and white. And I've always said there's no blood test for autism. So there hasn't been black and white assessments for autism, right? If there was a blood test, it would be black and white. You can't argue. There is an X-ray or whatever. You can't argue with that.
The blood types are real, but neurotypes are wishy-washy.
Right. But the thing is, parents come in and want to argue out the diagnosis all the time.
And where's the spectrum? Point to the spectrum on the map.
Yeah, I don't even know what this, I was trained with autistic disorder, pervasive developmental delay, and Asperger's. So I had to learn about this phantom spectrum because that wasn't what I was taught in school, that it didn't exist yet. So I've tried to explain to parents something that I wasn't taught myself necessarily of understanding. And I've come to adapt to the spectrum. But in terms of explaining the diagnosis out is very common for assessors and for parents and for teachers and for pediatricians. Everyone wants to explain it away. Mm-hmm. And I think the qEEG is going to help us with that concrete piece that you can't explain it away anymore. Like that's over.
I agree.
Well, the qEEG is not going to make diagnosis of autism either.
No, but it gives us more concrete information. It gives us that blood test that we don't have.
Right. It gives us concrete information, but it's another piece.
It's another piece to the information.
I have a patient who's a very prominent lawyer who, according to the EEG, should not be a lawyer. Because he has an auditory processing disorder. His left side of his brain is very, very slow. And yet he's a very successful lawyer who is very verbal and can write well. And he's taught himself how to do that. And when he and I talk about it, and now I'm seeing his child, who also has a language disorder, we talk about, but I made it. He says, I'm a lawyer. I have that same type of brain, but I'm a lawyer. And we talk about, yes, this is what you need to do with your son to help him develop those skills. There is something weird about them. Maybe it's weird in the sense of the way mental health people are. But for most mental health people that I've interacted with, and there's an openness and a kindness about really trying to understand people. And at the same time, like Myah, for instance, in our family, when people have had difficulty, let's say with a learning difference, all we do is roll up our sleeves and help.
Right.
And we go out and we find out exactly, okay, who's the expert in this area? What are the books? What do we need to look up? Where do we go? Where do we find the resources for that? And so we don't see as insurmountable, or blame game, and so that's, for your experience is so different, Neil, than for us.
That's why we're talking about accessibility, because as a poor person, a disabled person,
right,
an adult or a child, there's all these different ways that we get sorted. And then who's paying for it, and what's the information for? And then in my medical record, I don't even know what, I wasn't really cognizant of why did my parents at that year, I have to kind of rebuild the history of my family, and there were some really terrible things happening in 1968 in Utah, And my family was in Virginia, but it affected my mom because it was having to do with her family of origin. By the time 1970 rolls around, so I'm gestated in 69 during some really upsetting things that happened. And it was publicly upsetting. It wasn't just an internal family problem. I don't know, it probably made national news what was going on. And by the time she had me, she was a different mother. The context of her social standing had dropped significantly. If you think about the social and biological and psychological, what was going on in my family for the first 3 kids who are autistic is different for the last 3, were also very autistic. Their resources were then less than. We had less ability to do stuff in 1970 when I was born. So then I'm not receiving what I would call a co-regulatory bond or good enough affect regulation. So I'm now out looking for connection, which leads to me being preyed on by my mom's best friend's husband, who is a convicted sex offender. Mm-hmm. So by 1979, if they had just asked what's going on at home, or why are you flinching, any of these behaviors that happens not with autism, but with violence, victims of violence, in 1979, they didn't even touch any of that. Mm-hmm. I remember these assessments clearly, and I was very dissociated because of the level of abuse that I was under. Mm-hmm. So accessibility to me is very important, because if we can give more people the tools they need to understand why they're acting the way they are, then we can start to tease apart, well, this part of you we can understand through this lens, and this part is obviously something we need to stop immediately. This needs to stop immediately. We need an intervention right now. And we don't do that unless we have assessments. Mm-hmm. So it may be crimes, it may be maybe they're being poisoned by lead paint, maybe, who knows? But if we do the assessments, which includes, like we're saying, we do the blood work, and we do the EEG, and we do the neurocognitive, like how fast are you working? And what does it look like from last year? Like, why isn't a child being assessed every year so we actually have a map of what human development looks like? We don't have a big enough data set to say this is normative. We're just going off of this researcher with this many children says they should be speaking at this age. Maybe. And with the new world, that's why I'm asking, you like the Kennedy Center, it's a dark history, but yes, you got multidisciplinarians thinking about the medical needs of a child, great. What's happening today, in my experience, is all based on budget. Do we have the budget to help people? And right now, we don't. Mm-hmm. So one of the big elephants in the room we haven't even talked about is, if you want an assessment and know what your needs are, you go to those websites that allow you to do your own autism map. You answer the questions and you score a thing, and then you say, I'm autistic. That's the majority of people right now. The way they get their assessments is online, and they can get a number on that one metric. And how valid is that? And how much is that helping them with their actual co-occurring conditions? And then you can go to places like Neuroclastic, or you can go to STEM punks, or you can go to like people who are actively trying to make it accessible, give the information out about the autistic neurology, and you can read the books, Autistic Masking and Uniquely Human, and there's podcasts about it. These are people doing great work. I love it. I've learned a lot from it. I even brought these. This is just your grocery store. And I handed this to Myah today. And I'm like, Myah, have you seen all the information in here? And I went through and I'm like, oh, look, it's a pink page. I bet you this is about girls. Which, Myah, you can explain that better. Accessibility for women. How does that work?
Well, it's much less.
It's getting better, but...
No, it's getting better. I mean, that's why I was excited in this one. Autism in girls. Yay! I talk about autism in girls all day long. I mean, that's what led me, to my girl squad. But when I first started talking about it, years past, they said it's not in the DSM. It doesn't exist. It's not in the DSM. It doesn't exist. So you have to make it fit under autism spectrum disorder based on the DSM. And I've adapted to saying, well, it's a female phenotype of that. Yes, you're meeting the same criteria, but in different ways. So your examples of the trains or the cars might not be that, might be makeup or other things. So I've adapted it to fit the mold of the DSM, but at the same time, it's so different for a female phenotype presentation. And it still baffles me when I have a female in front of me and I'm like, I'm trying to figure it out. Again, a little easier when they come to me younger than older, but at the same place is very challenging with the girls because we are definitely, as a society, blinded with other factors that we're focused on with girls and boys.
Right.
And girls, come to the table very nicely. They come to the table with having a lot of memorized, picked up on this social thing they should be doing, so they're going to do it, versus boys are not as socially motivated as the girls. Girls, a lot of times, it is a very hard diagnosis for a girl to really say, I have autism, because they just want to fit into all the rest of the girls, the rest of the pack. Where boys, I feel, sometimes don't have that social motivation just yet to have some of that awareness to change their behavior to do that. They definitely also have the desire to fit in and to have friends, but I don't know if they have enough social motivation to mask as much as girls do.
And Jay, you talk about this with the social, biological. What are the 3 levels you work from?
Biopsychosocial.
Yeah.
Mm-hmm.
And so are there ethnicities or religious groups or countries even that don't exhibit autism because of socialization?
Well, according to our president,
Good
yes.
question.
He doesn't usually say stuff that he hasn't had someone research. So I'm pretty sure there's a person out there that he agrees with, and now he's echoing that.
Mm-hmm.
The societies that exclude people.
In and out group is socialization. In and out group is the entire problem with autism. I'm in the out group. I'm on that reservation called the spectrum.
Mm-hmm.
Sorry to get upset, but it's upsetting. It's dehumanizing.
Right.
So another place where you find this is with the Black community that are autistic. They actively put their kid in ABA therapy, even though the rest of the autistic community says don't ever do ABA. They do that because if that child doesn't learn to control their body in front of a cop and they run from the cop, they receive bullets in the back.
Right. Yeah.
So there's no one-size-fits-all doctrine of autism or autistic. Those are 2 different worlds. And the Venn diagram it's a bubble. There's not much overlap. In the autistic world, it's a social model, and we have to accept everyone's different. And you just watered down all my medical needs, and now I'm not going to get the resources I want. Fine, I'll hang out with you for an hour. But as soon as I'm in front of a doctor, I'm a person with autism. Because I've got to play both language models, or I'm not going to get what I need.
Mm-hmm.
I'm a person with autism, and I identify as autistic. I'm living in 2 worlds. One of the books I really like is How to Talk to Doctors. That book was great for my brain that models conversations. It taught me what a doctor is actually thinking about me. And I realized, he says, you don't have symptoms, you have complaints. And that one sentence in that book unlocked everything else. Oh, I am the complainer in the room. The patient complains, and from those complaints, the doctor creates the signs and symptoms. So when a doctor asks me for my symptoms, I always correct them now. I don't have symptoms, I have complaints. That is a bad position to be in your whole life, to be the complainer your whole life.
Right.
And when you have a lifelong condition and they want to check up on you, you have to complain about yourself.
Right. Well, I mean, that goes back to, I'm trying to reword, or first I reworded, the title of my reports now, and from psychological evaluation to diagnostic assessment, I'm now trying to figure out how to say whether you're presenting concerns
What are your complaints?
What are your complaints? Okay.
Let's use them. What I'm saying is let's make the medical model really sharp.
Right.
And let's use blood tests for blood test disease. And if it's a socialization disease, that's not part of medicine, that's part of something else.
Right.
More political.
Right.
But when I'm with a doctor, I need his help.
Right.
And if I act autistic, they don't want to work with me. If I get upset with their language, no, I'm a person with my own carriage. I'm in my own being, I'm autistic. Don't tell me I'm with You're just upsetting the doctor and then he can't do his process. Mm-hmm. I'm not even using good words right now because I've had so many bad experiences with doctors. When I'm thinking, no, I'm going to change the system, I'm going to give them this new language, and they're going to be like, finally, I understand autism as a neurological problem. That's not what people are trained in.
Right.
And they don't want to hear it from a patient because my job is to complain. So I got really good at complaining. Not just with doctors, I'm really good on hold with Social Security now. Mm-hmm. Or Verizon, like this unlocked everything. I'm a complainer. Okay, I'm going to complain nicely. If you don't complain nicely, you don't get help.
Right. Okay, so I'll ask what their complaints are.
Yeah, what are your complaints?
About your child.
Yes.
Because I'm seeing usually the child.
And this is a workshop. We just fixed one of your problems.
Okay.
I just want us to honor the medical model, especially the part where it says do no harm.
Right.
If we can have, and this is something that Kieran Rose talks about, you have to have reflective therapists. They have to reflect on their own implicit bias.
Right.
And they need a history of autism. They need to know that these children are being treated as schizophrenic. Implicit bias means that we are going to make these people not as human as we are. And one example of that is in the DSM. Jay might have been in that meeting. But what they would do is at the APA, they'd sit in a conference room and they'd talk about the diagnosis and then they'd vote on the symptoms. Mm-hmm. And one time they're all raising their hand and the one guy is like, and they're like, what, why didn't you raise your hand? He's like, well, I do that and I'm not crazy. And that's in the notes of the American Psychiatric Association. We literally have a book written of symptoms as long as the committee doesn't express them.
Right.
So there's already a bias in the bias in the bias in the bias because we're using language.
Mm-hmm. Well, that's what I'm saying. The bias is in the evaluator.
Yeah, that's one of those levels. Mm-hmm. But if we just say, okay, let's get as descriptive.
Right.
Let's get all the details. Then it's about connection and collaboration, clarity, not correction, coercion, control. Mm-hmm. In my opinion, it's very easy for people to model what you're doing, but they have to have the language for it.
Right.
And you're saying I have to be in person, and if I don't co-regulate, then all I'm witnessing is a bunch of trauma and not the actual neurology itself. That's what I'm hearing. Mm-hmm. That if you clear out the room and it has good energy, which is co-regulatory bond, then you can actually see what is native to that neurological specimen. Mm-hmm. And I love that because that's what I did with Dr. Broshek.
Right.
And then she wanted me to do a TED Talk. She sat there and listened to me for an hour and I said, Dr. Broshek, no one in my entire life, I'm 51 years old, no one has ever sat me down to think about, well, what does Neil think? And how does his brain work? Why are you doing this? And she said, because we never see people like you. Mm-hmm. And I said, well, I think you're wrong. I think there's a lot of people like me, but we're too stressed out to be talked to. We've become non-speaking in front of authoritarian doctors.
Well, I mean, we're at a turning point, though, because this generation will already have a lot of their diagnoses corrected, right?
Yeah.
So...
Is it this generation of the DSM or this age group?
This current age group of ones that were born with the DSM-5.
Yeah.
They versus...
See, I'm as a patient, I'm part of that. Sorry, I'm part of that generation. As a patient, doesn't matter my age. It's when medicine changes, there's a new generation of patient.
Right, but they don't get reassessed. That's what I'm saying. If you had bipolar, so for example, if you had a diagnosis of bipolar and you're 50 years old and you've lived a life of bipolar your whole life,
yes,
you're not going to go backwards of an assessment of doing a new narrative that now you have autism.
Which is sad
right.
for those people, but there is a preponderance of the online communities are creating a generation of people, no matter their age.
Right.
They're using online tools to assess their neurological needs, irregardless, that's not a word, but I still use it, of the medical model. Mm-hmm. And they're getting their needs met.
Right.
But they're rising to the bottom. They're not getting their economic needs met. They're not being part of society, but they finally have people that will listen to them and allow them to be autistic. Mm-hmm. And what I would like to do is have more access to verifiable, like Jay's saying. We need quality information in our medical records. That's the access need, not just about autism, but every part of our medical.
Right. Everyone, it's talking together, yes. Sharing information.
Like the Kennedy Center.
Right.
I knew where you were going with that, Jay, and I'm saying right now, do we have that? And in the future, if we don't, can we get that? Can we get these things accessible to people like me?
No, because our president's saying that he wants to eradicate autism and get rid of it versus coming up with infrastructure to support it.
Yeah, and here's the other thing about, it's called the curb cutter effect. Mm-hmm. How many of you guys remember curbs without the handicap ramps?
No, I don't.
Right.
So who uses the wheelchair ramp? It's expensive. Remember in the 80s and then the ADA in the 90s?
Yes.
And then we started having wheelchair ramps on every building. Mm-hmm. That started in the 90s. Mm-hmm. So who benefits from having ramps? If you have a presentation in a building and you have to haul in your overhead projector and your briefcase and your dolly, the majority of wheelchair ramps are used by people getting work done, not by wheelchair users.
Yeah.
So it's not expensive. It actually made life easier
for everyone.
And now we have less auto bike accidents because bikes can easily get onto the sidewalk. Where before they'd have to hit the curb.
Right. So we just need to figure out what's a general support that goes across different individuals.
That's not even the next episode.
Are we good?
He should be able to hear you.
Do you hear me? Do you hear me?
Yeah.
Okay, perfect. Until next time, we're here for you.
This podcast, 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 this podcast was for entertainment and general information. It does not constitute medical advice or create a patient-doctor relationship. But what you can do is find qualified medical professionals to meet your diagnosis and treatment needs. And I would love for you to have a sense of purpose. And then you can go do your stuff.